This meeting is being recorded.
Okay. Thank you everyone for joining us today for the South Texas Regional Family Medicine Grand Rounds. Our educational partner is the South Central Area Health Education Center. Our department's mission statement is inventing a healthier future for families and communities in San Antonio, South Texas, and beyond through excellence in patient-centered care, research, and education. Next slide, please. All right, thank you all in advance for muting your microphone once the presentation begins, being attentive to the presenter and engaged in the session, and completing and submitting a session evaluation form. Next, please. All right, so today is November 9th, 2022. Don't forget to register your attendance and claim the credit. The CME credit via text process is explained in the email reminders that you got today. You must register for each session by midnight in order to receive CME credit. Next, please. All right, the new CME system. So step one, send a text to that number with just the email address connected to your CME profile. They'll connect your responses, and then a text attend plus your code for today, which is 100900765. Next, please. You can access your CME transcripts at the Long School of Medicine CME website, cme.utisca.edu. You can follow the instructions on the screen to view and print your CME transcript. Next, please. AFP members, please ensure that you have submitted your AFP ID number for credit. This live activity, the South Texas Regional Family Medicine Grand Rounds, has been reviewed and is acceptable for up to one prescribed credit by the AFP. Physicians should only claim the credit commensurate to the extent of their participation in the activity. If you have questions regarding your CME credits, please contact the AAFP. Next, please. So here are the FCM Grand Rounds nationally established vision core competencies for review. All right, next slide, please. Dr. Rene Camacho, our presenter for today, has no financial relationships or with ineligible companies to disclose at this time. All right, and Dr. Camacho, I believe the next slide is yours.
Thank you so much. All right, good afternoon, everyone. My name is Rene Camacho. I'm a staff physiatrist here at Audie Murphy in San Antonio, Texas. I work in the PM&R and polytrauma department. I'm also adjunct faculty with the UT Health San Antonio PM&R residency program. And my primary clinical duty and educational role is in electrodiagnostics, which is what we'll be discussing today. So here's some of the goals that I wanted to set for this lecture. This presentation is define what electrodiagnostics are, explain what information nerve conduction studies and EMG can provide and how these tests can be used. We want to identify the risks, contraindications, and limitations of electrodiagnostics. And then I wanted to just give some information that you may be able to provide that can help your respective consultant when including electrodiagnostics in your treatment plan. So what are electrodiagnostics? They are extracellular tests or recording that can allow for physiologic assessment of the nervous system. So you may be familiar with some of these, including EEG. Although not part of the nervous system itself, you're also familiar with EKG, and you may be familiar with EMG or electromyography. In this umbrella term of electrodiagnostics, as they pertain to the peripheral nervous system, we also include nerve conduction studies. And their performance involves using surface electrodes or needle EMG. And this allows you to take an extracellular recording of the action potential going on within the muscle or the nerve fiber. It's a dynamic test. So unlike the EKG or the EEG, you may start it the same way, but depending on what you do or don't find, it may change. And it reflects the provider's history and physical. And so I'll talk a little bit more about this during the presentation, but these are more specific tests done in the appropriate patient, as opposed to them being sensitive tests and useful for necessarily ruling things out. So I'm taking a lot of y'all back to the early years of your educational training, but I want to do this just to help give you a better appreciation of how these tests can be used and what some of their limitations may be. So I included these two pathways for afferent intersensory input into the nervous system. On the left-hand side, we have the light touch and proprioception pathway, or the dorsal column medial lemniscal pathway. And on the right side of the screen, we have our pain and temperature pathway, or the spinal thalamic tract pathway. Unfortunately, because of how small some of these nerve fibers are in the peripheral nervous system, nerve conduction studies are not useful in really assessing those type of fibers. Whereas these larger fibers that transmit light touch and vibration and positional sense, nerve conduction studies are more helpful in pathology affecting these fibers. So in clinic, you may see a patient that says, hey, you know, I got more prickling, pain, burning. You know, electrodiagnostics may have a lower utility in that particular patient, as opposed to a patient who has maybe 10 out of 12 monofilament sites absent, or, you know, they can't tell where their toe is in space. That may be a patient in which electrodiagnostics serve higher utility. And amongst these, remember, we have three order neurons. You've got the first, the second, and the third. We can really only look from skin to dorsal root ganglion. We can't test anything more central than that with electrodiagnostics. Here we have our motor pathway, or our cortical spinal tract pathway. And in our electrodiagnostic assessment, we can only really look from the anterior horn cell down to the muscle fiber and all the axons that are included. So really, these tests are only helpful for looking at the peripheral nervous system. If you suspect your patient might have a central insult, like a stroke, they're not good for MS, a Brown-Sequard type syndrome, these tests most likely will not be that helpful. And if they do show abnormality, it'll be very nonspecific. A little bit more of review, again, just to give you an appreciation of how these tests can serve you in a particular patient care. When conceptualizing a portion of the peripheral nervous system, we're always thinking about a cell body. We're thinking about axons, and then we're thinking about its terminal branches, whether that's to skin receptors or muscle fibers. And then during electrodiagnostics, we're always thinking about axon integrity and myelin integrity. And so simply put, that'll tell us kind of the speed and the size of the responses of our testing, okay? And we already talked a little bit about this, of the portion of the peripheral nervous system that we can study. So I included these next two charts that can serve as a reference. When you have a patient that's presenting with particular signs and symptoms, this graph can kind of help you triage or develop a differential diagnosis as to what they may be experiencing, right? So you got a patient that has just weakness with no sensory symptoms. You know, your differential might include things like ALS, myasthenia gravis. Whereas if you have a patient that's telling you, hey, I've got numbness and tingling in my thumb, index finger, and middle finger, and I really don't feel it past my forearm, you know, you might be thinking something more focal, like a median mononeuropathy. This table also includes different root levels and their particular sensory disturbances where you would expect them, what muscles you would expect to be weak, and what reflexes may be affected. And so this helps guide kind of your suspicion, and it may help your electrodiagnostician better focus their efforts during their electrodiagnostic study. So that's for the upper limb. Here's more of the graph for the lower limb. Okay, so what information can electrodiagnostics, you know, provide me as a provider? How can these tests actually be used? Well, these tests should be considered an extension of your history and your physical exam. And earlier I mentioned that they're more specific in the correct patient. So someone who says, hey, I've got numbness and tingling to these 3 digits, they're these 3.5, you might suspect a median amount of neuropathy. These tests can help you rule in by finding electrodiagnostic evidence to support that clinical entity. They're not so good for screening. And so one example that comes to mind, I don't know if it was here in San Antonio or elsewhere, but an automotive company that was screening their mechanics, whether or not they had symptoms. That's probably not the best use of this test because unfortunately, if a nerve has been injured and looked pathologic on electrodiagnostic testing, it may look like that regardless if their clinical symptoms improve. So these tests are better to rule in the correct patient as opposed to ruling out in a screening manner. And so they're useful for patients who have consistent or persistent signs and symptoms, paresthesias, hyposthesias, weakness, and they can look for that electrodiagnostic evidence to support what you're thinking about. They're not so helpful for patients who say they have, fleeting or temporary symptoms, who you think may have a neuritis as opposed to a neuropathy. They may not be that helpful. As we mentioned, they can assess the physiology of the peripheral nervous system. And inherently, just some portions of the peripheral nervous system can be easier or more thoroughly assessed. For example, the median nerve at the wrist, very easy to assess, versus the thoracic nerve roots and the muscular of the thorax, very difficult to assess. A lot of overlapping nerve supply and not any nerve conduction studies that we can do, very few needle EMG studies that we can do there. They do a pretty good job at assessing the cervical and lumbosacral nerve roots. So if you suspect a radiculopathy in a patient, they may be helpful in that regard. They can allow you to look at the integrity of the brachial or the lumbosacral plexus. Probably more helpful for the brachial plexus as opposed to the lumbosacral just because of some technical limitations, but still helpful in both nonetheless. You can look at individual nerves, the median nerve, the ulnar nerve, the radial nerve, the common fibular nerve around the knee. It can allow you to look at the neuromuscular junction, so myasthenia gravis, Lambert-Eaton myasthenic syndrome. You can look at the muscle itself. So there are particular studies that we can do to help look for evidence of a myopathic process. So here's a snapshot of what a typical nerve conduction study would look like. We use a small remote-like probe, delivers small amounts of current, no more than 100 milliamps most of the time. And we use surface electrodes to record over the signal generator. So in this case, we're recording over the abductor pollicis of the thenar eminence, but we may use other types of electrodes to record sensory nerves. So this would be an example of the nerve conduction studies that we would do on a regular basis. This would be an example of a needle EMG that we do. And so we use a small, solid, it almost looks like an acupuncture size pin, and it's relatively the same gauge, that we would insert into muscles of concern, and then we would record the electrical signals and look for any abnormalities and basically puzzle together, where could these be coming from? As we mentioned, the different sites of the peripheral nervous system a few slides ago. So what else can these tests provide? Well, they may be able to tell us about how to qualify and quantify the type of lesion. What do I mean? So we may be able to comment on, does the lesion appear to be mostly demyelinating? Is there a component of conduction block or signal not making it through across a particular site of concern? It may be able to tell us, is there axonal loss or actual death of the axonal projection to the muscle fiber? Does this lesion look to be partial or complete? And then based on this detail, we might be able to give an opinion on prognosis. If there's no signal coming through, that would lend to a worse prognosis than if there's some signal coming through. Different specialties that you may then take this information via consultation, whether it's neurosurgery or pain management, they may be able to use some of these findings. And there is some emerging literature that patients who have a radiculopathy with EMG supported findings tend to do better with an epidural steroid injection, or laminectomies with decompression, as opposed to patients who don't have electrodiagnostically supported radiculopathy. Now, some of these details as far as demyelinating, axonal loss, how old is the lesion, it tends to be a little more accurate for patients who have a one-time insult. So if you do have a patient in clinic that, had a trauma, had a fall, we have a clear, onset of insult, these are the type of patients that we could most accurately make a comment on, as opposed to a patient who may have been having on and off symptoms for 20 plus years. Those would be a little more difficult to give as much detail as possible on. So what do I tell patients? Do these tests have risks? What should they be aware of? These tests are relatively low risk, but patients will still have some adverse effects, namely discomfort. Most of the time, the needle EMG tends to be more uncomfortable for patients as opposed to the nerve conduction studies. But even the same patient can have the same exam from two different providers, and the needle just be in a different place, and it could be more or less comfortable. Some muscles may be associated with more pain, such as the muscles of the foot and the muscles closer to the ankle, or the muscles of the hand. It's not uncommon for patients to have a little bit of soreness, maybe some bruising for a day or two after the exam. The best way I could describe them, the nerve conductions with the little stimulator that we use really feel like a small jolt. Some patients describe it as a TENS unit, or like a snapping rubber band on their skin. And some patients describe the EMG, the needle portion, feeling like a vaccination administration or a muscle cramp. But most patients tend to do fairly well, but discomfort, soreness, and bruising would be the biggest things to let your patients know that could happen. What about other things like infection, bleeding? Can you injure any of these structures? As I mentioned before, we use a very small gauge pin. It's a solid pin. It's about 26 gauge. Even though there hasn't been clear evidence that prepping or not prepping with alcohol makes a difference, in our lab, we prep with alcohol prior to insertion into the skin. When you look at the literature, all the infection reports have been with reusable needles that are autoclaved and reused. We use disposable one-time use needles. And even in patients with lymphedema, the risk of infection is very low. Nonetheless, if you have a patient that has more than trace pitting edema in the lower limbs, it may be a good idea to control this before having them come to the lab, because it could be a little unsettling for a patient later that day or the next day to see, oh, my leg was weeping all day because of the needle EMG they did. Bleeding risk is actually surprisingly very low. So we'll do these studies in any patient on anticoagulation. We get most concerned in patients who are on warfarin, who don't have a recent INR or an INR that has shown stability over the last few months. When you look at the literature, though, the relative risk in a lot of anticoagulated versus non-coagulated patients, it's not impressive. One paper that I was looking at, the relative risk in uncoagulated patients, unanticoagulated, 1.02 versus 1.35 in those receiving anticoagulation. And it tends to occur with muscles in deeper compartments. So the deep posterior compartment muscles of the leg, the paraspinals of the neck and low back. But even in these patients, a lot of these hematomas were incidentally found because they were just looking for them. They had no symptomatic correlation with their presence. Patients also ask, is there a risk that I can get a tissue injury or any kind of injury from the electrical shock? The answer is no, unless there's an IJ line and you're stimulating by Erb's point, the risk of injury is little to none. Even in patients who have deep brain stimulators or spinal cord stimulators, pacemakers, we do these no problem. We just avoid, areas that are near near those devices. So for example, if a patient has a pacemaker, we wouldn't go stimulating Erb's point by the clavicle. The one probably pertinent risk that I have seen, and I do have a colleague who this happened to, was pneumothorax, and that tends to happen more in the axial musculature. So if you send a patient for a radiculopathy workup and they're going to get their lower neck muscles assessed or their thoracic paraspinals assessed, these tend to have the highest risk, and it may be in patients who have COPD. You know, if someone has bullous emphysema, that might be a concern. But I would say 99% of our patients in the clinic have no issues with even some of these riskier muscles being assessed. Are there any contraindications to electrodiagnostics or particularly needle EMG? The answers are no absolute contraindications, but they may be higher risk in a particular subset of patients. So those who have thrombocytopenia with platelets under 50,000, those with chronic kidney disease, coagulopathic patients, relatively speaking, those on antiplatelets or anticoagulation, those with implanted electrical devices. But I'm here to tell you it's relatively no risk as long as there's not a particular cumbersome workup with Erb's point stimulation going on. Those with skin breakdown, or those with active wounds in the area that might be studied. So if you suspect a patient has a radiculopathy, and maybe they just had a recent nerve graft, or not nerve graft, skin graft that's healing, that may be a patient that, holding off on the EMG until that area heals may be a good idea. And edema. The other thing about edema that I failed to mention earlier is sometimes when there's excess edema, especially in the lower limbs, this just puts a lot of signal impedance. So we have a hard time recording with a surface electrode, recording a cutaneous nerve when there's all this fluid in between the signal generator and the electrode. So that may be another thing to consider if your patient has edema. Even just TED hose, wearing TED hose the day of the exam. That way, when they get to our lab, it's a little better controlled, can make a significant difference. So what about the limitations? So I think there's a misconception sometimes that electrodiagnostics are themselves a gold standard, but the truth is, for a lot of the entities they're used for, there is no gold standard. And what I mean is, there's no gold standard for carpal tunnel syndrome. And the way histopathology is a gold standard for malignancy, we don't have that with a lot of these peripheral nervous system injuries. So to actually comment on true sensitivities and specificities is difficult because we don't have that gold standard. I alluded to this a little earlier. We look at speed and we look at the size of responses. And these are essentially compared to normal or normative values that were done at larger institutions, and we use their normative values. One limitation is some patients may not fall within the upper or lower limit of normal. And so it's not uncommon that you may see a patient in clinic and you do a physical exam and you're fairly confident they have carpal tunnel syndrome, but you send them to the electrodiagnostic lab and they don't have any electrodiagnostic evidence of carpal tunnel syndrome. Well, that doesn't mean they don't have the syndrome itself. It just means we can't find the electrodiagnostic evidence. Either it's not profound enough to have had an impact on the electrophysiology, or they still fall within those normative values. Their range is, if their range was here, they're still falling within those upper and lower limits of normal. And grading of electrodiagnostics is not something that's agreed upon. So sometimes I've seen these studies kind of ordered to say, hey, well, do you think it's a mild, moderate, or a severe problem? The issue is there's no agreed upon nomenclature for that. And so I've seen patients that have the slightest abnormalities on their electrodiagnostic studies, yet the most profound signs and symptoms on history and physical. Whereas I've seen patients who have what some would call a moderate or more severe findings on electrodiagnostics, but they don't have as profound signs and symptoms, or they're asymptomatic. That's another reason I was saying, these tests, they're more specific in the right patients, but they may not be as sensitive to rule things out. And as we mentioned earlier, nerves or muscles that have been injured may always appear abnormal electrodiagnostically, just because of the way the nerves tend to heal. That segment may always be smaller, slower. And so if a patient has had electrodiagnostics, just knowing that they may always look abnormal if you're going to reorder them might be something to keep in mind. Very good. A little bit more on limitations and utility. So I think the median nerve at the wrist is probably the most studied, most well known as far as electrodiagnostic utility goes. And I know I'm mentioning sensitivities and specificities despite there not being a gold standard, but I just wanted to mention what some of the literature touches on. So the estimated sensitivity for the median nerve at the wrist would be about 56 to 85%, and the specificity anywhere from 94 to 99%. The ulnar nerve is not as clear because there's less robust amount of data, and over the last couple of years, there's been a kind of a discord with different entities in the electrodiagnostic community having different opinions on what is normal, what's abnormal. But the sensitivities are estimated to range from 71 to 81% in the ulnar nerve. Radiculopathy, the sensitivity of EMG ranges from about 50 to 85% with higher specificities. Some of the literature says up to 100%. The interesting thing, though, is that when we're testing with electrodiagnostics to look for a radiculopathy, we can only look at the motor portion of the nerve root. There's not a good electrodiagnostic test to look at the sensory portion. Even though we can study sensory nerves with nerve conductions, because of how the pathology of a radiculopathy works, those aren't as helpful. Polyneuropathy or a length-dependent neuropathy, as we mentioned, only tests the larger fibers. So if a patient has light touch, proprioception, or vibration deficits based on their signs and symptoms, this electrodiagnostics may serve to help support your conclusion. And the thing to keep in mind, though, is this won't tell you what's causing the polyneuropathy. What I mean by that is most of the acquired polyneuropathies, like diabetes, B12 deficiency, neuropathy from chronic kidney disease, they're going to look the same on electrodiagnostics. So these most likely won't be able to tell you what's causing the neuropathy. Unless it's something obscure like Guillain-Barré syndrome, which is the type of acquired polyneuropathy. Electrodiagnostics most likely will not be helpful in determining the etiology. Tarsal tunnel syndrome. So there's level C evidence, so neither strong enough to argue in favor of using electrodiagnostics or to argue against using electrodiagnostics. And that's just a technical limitation because of the dimensions of the foot and some of the technical challenges that we come across when studying the foot with electrodiagnostics. As we mentioned earlier, plexopathies, it's often a higher yield to study the brachial and the lumbosacral plexus, but still, electrodiagnostics can be helpful in both. So I included these diagrams of dermatomal distributions, and you can reference these in the previous charts that I provided. And they can serve, kind of to help with the history and physical to help guide what you may be suspecting. I included individual distributions of nerves of the upper limb and also of the lower limb. So those are here. Now, one goal that I wanted to touch on was, well, what information can help the consultant, or how can you get the most bang for your buck on electrodiagnostic consults? Because a lot of times, I'll be fielding consults that just say kind of numbness and tingling. And, we'll schedule the patient for a set amount of time when in reality, we probably could have used more time and done these electrodiagnostics all at once. And so I just wanted to give you information that could help you, help the consultant, and help the patient. So a couple things that may help is, how long have the symptoms been going on? What has been the duration of the symptoms? Even though symptom onset doesn't necessarily mean that's when the electrophysiologic abnormality started, this could be helpful. I say that because, in the animal models that were done to look at, how do nerves react to injury, a lot of times it seemed like 3 weeks was enough time from like a complete transection to allow for changes to occur in the most distal muscles. So I'm not saying that electrodiagnostics wouldn't be helpful, sooner than 3 weeks. But if you had a patient who said, just developed symptoms 10 days ago, and then they have their studies done on day 14, a normal study doesn't necessarily, rule out pathology. That may be a patient that you'd want to repeat again after 3 weeks have passed to allow enough time for that electrophysiologic abnormality to set in. Knowing if there was a inciting event or trauma may help, because certain traumas, traction injuries, may be associated with certain pathologies such as nerve root avulsion. What is the distribution of the symptoms? Do they seem more stocking glove? Do they seem limited to an individual nerve? Do they seem to radiate from the cervical spine down a particular dermatome? Has the area that you want to have studied had any trauma or instrumentation? For example, if you're thinking about having the median nerve at the wrist assessed, have they had a carpal tunnel release, or have they had any instrumentation to their ankles if you want their lower limb studied? This just helps us because if they've had a carpal tunnel release, or if they've had carpal tunnel before, like we were talking about, an injured nerve, even though there's clinical resolution, may always look abnormal electrodiagnostically. And sometimes it is hard to compare. The best thing is to have the same provider do the same test, but sometimes, our patients are coming from other institutions or other cities, and it's hard to sometimes quality control for an outside lab. And so that information is helpful. Or if they have studies they can bring to their appointment, that may help, us kind of better opine on their lesion or the severity of their lesion compared to prior testing. Are there any findings on physical exams? So whether that's decreased monofilament testing, muscle atrophy on inspection, or weakness on manual muscle testing. And I included them here. I know they're on the previous graph, but sometimes it's just nice to have a quick, easy reference to look back on. But this would help us because, if a patient does have muscle weakness or muscle atrophy, we know, okay, higher index of suspicion, this is probably a patient we want to dedicate a little more time to. That way the patient doesn't have to be, coming for 2 separate visits. We can get them all done at once and get them an answer and help kind of move their care along to get them the relief they're looking for. If the patient is new to your particular institution, it may be helpful to know, do they have risk factors for a polyneuropathy? Do they have a longstanding history of diabetes or vitamin deficiencies, heavy alcohol intake, amyloidosis, anything you think might impair the integrity of their nerves at their most distal points? All right. Well, that's the end of my presentation. I wanted to leave a bit of room for any questions. I'm happy to answer any questions you may have related to the material we went over. We went over even, what do we do after we get the electrodiagnostics? Is there kind of a general pearl you can give us to help triage some of these patients? I'm happy to answer however I can. These are my references, and that is it.
Okay. Well, if no one has any questions, thank you guys for attending today. Make sure you register for your CME credit. And have a good afternoon. Thank you, Dr. Camacho.
Okay. Thank you, everyone.
Thank you.
Thank you, Dr. Camacho. Excellent presentation.
Thank you so much. Thank you for having me.
Have a great week. What's left of it?
Thanks, y'all too.